So today's lecture is adrenergic agonist, and uh, the these drugs are divided to direct acting and indirect acting, and the formula of the most commonly used drug looks like this: adrenaline and noradrenaline. And if you look at the formula, the primary part is the catechol that has a aromatic ring with two hydroxy groups, and same here. Then the ethylene bridge, it connects this catechol with the amino group and the primary amino group in noradrenaline and secondary amino group in adrenaline. So this both adrenaline and noradrenaline are non-selective adrenomimetics that activate both alpha and beta adrenal receptors. And if we look at the sympathetic or nerve ending, we can see that the noradrenaline is synthesized in the nerve ending from tyrosine. Tyrosine is uh, converted to the deoxyphenylalanine or L-DOPA, then to the dopamine, and dopamine is further converted to norepinephrine in the vesicles. And when the end plate current arrives, these vesicles will release norepinephrine to the synaptic cleft, and norepinephrine, once released, can activate postsynaptic alpha or beta adrenoreceptors or presynaptic alpha-2 adrenoreceptors. By activating the postsynaptic receptors, it will lead to the contraction of the muscle. But by activating presynaptic alpha-2 adrenoreceptors, it will inhibit the release of the norepinephrine from the synaptic cleft. Further, this norepinephrine can be destroyed by the catechol or methyltransferase, that is a specific enzyme that will destroy catechol amine, or can be reuptaken by the synaptic cleft by the norepinephrine transferase, and further destroyed by the monoamino oxidase, that is intracellular enzyme, or can be stored in the vesicles directly further. So this is how the norepinephrine is released in the synaptic cleft. And there are those synaptic cleft are located in the postganglionic neurons of the sympathetic nervous system. So this is actually the structure of the sympathetic nervous system. Neuron from the central nervous system, brain or spinal cord, goes to the ganglia, and in ganglia we have acetylcholine and nicotinic receptors. And the second postganglionic neuron is adrenergic neuron, and that is why it releases norepinephrine that acts on alpha or beta receptors. And then there is also adrenaline that is released to the blood, and the adrenaline released from the adrenal medulla to that is also stimulated by the acetylcholine, and we can look at this as a large synaptic cleft that stores adrenaline, and then it's delivered by the blood to the specific receptor in the heart vessel, and that will actually activate these receptors. Uh, the uh, epinephrine and norepinephrine are released both in adrenal medulla, but most of the composition is 80% is epinephrine. So there are two types of the alpha subtypes of two alpha receptors, alpha 1 and alpha 2. Alpha 1 is located in the vessels and primarily lead to the vasoconstriction of the vessels. And in the eye, the stimulation of alpha 1 leads to the mydriasis. In the bladder, it leads to the contraction of the sphincter and urinary retention. In the liver, the stimulates the glucogenolysis that will produce some glycogen uh, from the glucose in the blood and store it in the liver, and then in kidneys will reduce secretion of the renin. Then alpha 2 are mostly presynaptic that inhibit the release of the noradrenaline and also can be found uh, uh, in the beta cells of the Langerhans cells, uh, and the stimulation of the alpha 2 will reduce the secretion of the insulin from the pancreas. Okay, so then there are beta receptors. Beta receptors are divided to beta 1, 2, and 3. Beta 1 are mostly located in the heart, and activation of the beta 1 in the heart increases heart rate, contractility, and atrioventricular conduction in the heart. And in the kidneys, the beta 1 increase renin and increase blood pressure. That is opposite to the action of the alpha 1 receptors in the kidneys. Then beta 2 receptors in smooth muscles of different organs lead to the relaxation of these muscles. That includes bronchodilation in the lungs, vasodilation in the vessels, and inhibition of the GI motility in the stomach and intestine, and inhibition of labor in uterus, and also increase in the insulin secretion. So in alpha we have a decrease of the insulin secretion, that is opposite. Then we have a beta 3 receptors that increase lipolysis in the fat tissues and relaxation, lead to the relaxation of the urinary bladder. So these are the effects of the beta receptors. And when it comes to the agonists, adrenergic agonists, they can be divided to two groups, catecholamine and non-catecholamine. So catecholamine are those that have a catechol group, and that is why they are susceptible to the catechol methyltransferase. That means short acting and also not effective with oral administration, like for example adrenaline. So adrenaline is actually catechol ethyl amine. So this is the chemical structure of the adrenaline, and the differences between the adrenaline and all catecholamines and non-catecholamines is that catechols are orally ineffective, and the duration of action is short, and they have poor central nervous system penetration. While the non-catecholamines have an opposite effect, they have a good oral bioavailability, a long duration of action, and good central nervous system penetration. So the direct acting agonists uh, that are non-selective can be divided to three. Epinephrine, uh, the one we just discussed, and mostly indicated for uh, vasoconstriction, increase of the blood pressure, increase of the cardiac output, and for bronchodilation. So these are primary indications of the epinephrine. Norepinephrine is mostly used as a vasoconstrictive to increase the blood pressure because it mostly acts on the vessels. And dopamine uh, will have different effects depending on the dose. In low doses will activate the dopaminic receptors, and in medium doses will activate beta 1 in the heart, and in the higher doses alpha 1 in the vessels. So depending on the dose there will be different action of the dopamine. Then if we look at the direct acting agonists that are non-catecholamine, we have oxymetazoline and phenylephrine that are alpha 1 selective agonists that are indicated for the running nose and also used in ophthalmology to decrease the red uh, to decrease the syndrome of the red eyes. Then the alpha 2 agonist clonidine is centrally acting alpha 2 agonist that decreases blood pressure, and beta agonists that are dobutamine for the treatment of the heart failure, and beta 2 uh, in, inhalation inhaled uh, agonists that are further divided to short-acting and long-acting. Short-acting are albuterol and terbutaline, and long-acting salbutamol and formoterol. All of these are indicated for the asthmatic patients. And the beta 3 agonist mirabegron is indicated for the treatment of the urinary retention. And if we look at the indirect acting agonists, they have a zombie-like effect for the humans. So because they decrease the reuptake and increase secretion of the catecholamines, including norepinephrine and epinephrine, and that leads to the blood pressure increase and heart rate increase. So both of these, cocaine and amphetamine, are not considered drugs, but are drugs of abuse. And mixed action is the ephedrine and pseudoephedrine. So these drugs are used for the treatment of the asthmatic patient and also for the running nose. So unlike the catecholamines, the lack of the catechol group, that is why long action and there are also some amino group and methyl groups nearby. So the pseudoephedrine also can decrease inflammation and decrease the secretion of the mucus in the nasal mucosa. So that is for the